Good afternoon. Welcome to the Assembly Committee on Health and Human Services on this Friday afternoon. Secretary, will you please call roll? Assembly members Dahlia, here. Edgeworth, present. Gonzalez, here. Goulding, here. Gray, Hafen, Hibbets, here. Hunt, here. Jackson, Koenig, here. Nadim, Wynn, here. Orntlicker, here. Chair Brown-May. And I am here. Please mark Assemblymember Gray present as he has just arrived, and Assemblymember Hafen absent excused for today. Thank you. Okay, welcome to our audience here in Carson City, those joining us by video conference and anyone who is joining us in Las Vegas. A couple of housekeeping announcements as we begin today. First, I would like to remind you all to please silence your electronic devices so that they don't go off during our meeting. Members of the public may provide public comment or testimony in various ways, all of which are listed on our agenda. To provide public comment or testimony by telephone, you'll call 888-475-4499, and then when prompted, provide the meeting ID, which is 810-9648-9440, and then press the pound sign when prompted. You may also submit your public comments in writing, either in addition to testifying or in lieu thereof. Written public comments may be submitted before, during, or up to 24 hours after the meeting adjourns. If you wish to testify in person, please sign in at the table by the door and leave us a business card if you have one. If you do not testify, you may also want to sign in so that we have a record of who is interested in any particular activity, event, or measure that we're working on, and then we can contact you later. To ensure an orderly flow of discussion, all comments, questions, and responses must come through the chair. Also, committee members must be recognized by the chair before speaking. When testifying in person, please turn on microphones and then off when it's time to listen, because we do have others listening and viewing in meetings throughout Las Vegas and online. With that, we will now move on to our agenda today. I would like to welcome members who are going to do a presentation from Mental Health and Behavioral Health Services here in Nevada. So we have with us the Division of Public and Behavioral Health Administrator Cody Finney, the Division of Child and Family Services Administrator Marla McDade-Williams, the Division of Healthcare Finance and Policy Administrator Stacy Weeks, and the Director's Office Deputy Director of Programs Shannon Litz. Ladies, you may begin whenever you are ready.
Chair, committee members, thank you for having us, and happy Friday. Stacy Weeks for the record, Division of Healthcare Financing and Policy. Like the chair mentioned, I have here with me today Cody Finney, Administrator at DBPH, and Marla McDade-Williams from DCFS. We're going to zip through a couple of these slides and then make sure we have time for questions. So I'm going to go here to the second slide. So just real quick, when you're looking at behavioral health in Nevada at the state government level at DHHS, there's three of us as divisions that have our role to play. There's DBPH, which is Cody's division. There's DCFS, as you can see the mission there around children and child welfare. That's Marla McDade-Williams' division. And then DHCFP, which is our Medicaid program, and we're a big payer in that program. This slide here kind of gives you a high-level overview or high-level vision or visual of kind of our roles. So when you think of behavioral health as sort of all of our goals around around behavioral health, DHCFP is really that payer for services. Nearly 1 in 2 kids are covered by Medicaid in Nevada. So we do play a big role, and often we cover a lot of services that are not covered in the private market. DBPH is the service provider. Also, they have block grants around behavioral health services, and they also are a regulator for some of our facilities, and they do the licensure pieces. DCFS plays the role of the child service provider for a lot of children in our foster care system and who have other needs, especially in our rural areas, as well as they receive Title IV funding as well as other block grants and funding for children's behavioral health. And I'm going to go ahead and move quickly so that way Cody can start her slides. Thank you.
Thank you very much. Please excuse the mask. I am starting to lose my voice, and just in case it's viral, I didn't want to expose my colleagues. My name is Cody Finney. I serve as the administrator of the Division of Public and Behavioral Health. I'm going to skip straight to slide number 9. Slide number 9 describes some of the detail about our crisis response services. This is managed out of our Bureau of Behavioral Health, Wellness, and Prevention. The previous slides give you a higher level breakdown of how we're providing behavioral health services. Our Bureau of Behavioral Health, Wellness, and Prevention is really the public health part of behavioral health. This is where we're providing grants to the community, overseeing this large system that's for the entire community to address crisis service needs. And we're working with partners, private providers, to provide those services. We've had great strides this interim on our 988 and crisis response system. We've got a contract in place with Carillon. We've got crisis stabilization centers opening. We're very happy to talk more about that at any time, about the progress that's being made there. On slide 10, it describes our civil mental health services. This is really just a safety net. Most services are provided by private providers, but where there are individuals who are either too severely impacted by their mental health issue or don't have any other payer source, we provide some safety net services. And next we have our forensic mental health services. This is where we are statutorily obligated to provide services for individuals who need to be restored to competency, and also long-term commitment for people who have been determined unable to proceed or not guilty by reason of insanity. Excuse me. We've made some great strides this interim as well on this. We have been fined in places for the length of time it takes to get people from the jail to these services, but we've had some great improvements with a number of ARPA-funded programs to address that, and we've had support in the governor's budget to continue to address that further. We are seeing the growth in this demand for this service nationwide, so a very high level of focus for us at this time. On slide number 12, it gives you the particular statutes for each of the populations that we serve in that forensic mental health service system. And number 13 is some challenges that I mentioned and some successes that we've had in this interim about addressing some of those long wait times and large numbers of people waiting. On slide 14, you'll see I mentioned our Bureau of Behavioral Health, Wellness, and Prevention. Again, the public health part of behavioral health. This is where we really intersect with substance abuse. When I say behavioral health, I mean substance abuse and mental health, and sometimes those go together and sometimes they don't. But this bureau, lots of funding going out into the community and the oversight of those crisis services. With that, I'm going to stop and let Shannon have this chair.
Good afternoon, Chair, members of the committee. My name is Shannon Litz, Deputy Director of Health and Human Services for the record. We wanted Cody to mention the services provided at DPBH and then also to add in here the Fund for Resilient Nevada that I know many of you have heard about earlier this week and in other meetings, just to kind of recognize the difference in these funding sources. So the Fund for Resilient Nevada is the state's portion of our opioid settlement funds. It's being awarded to projects and programs that fit within the 7 goals and the priority populations we're working to serve: veterans, pregnant women, youth, LGBTQ, juvenile justice involved, and children in the welfare system. The annual report for the Fund for Resilient Nevada just came out this past week, and I will make sure that that is sent over to all of you. Any of you that sit on the Interim Finance Committee have heard that we're doing lots of projects and programs related to pregnant women and children and infants. Last summer, the Office of Analytics published a report on the health outcomes of infants with gestational exposure to substances. And that included data from 2018 to 2020 outlining that more than 12% of infants born were identified as being gestationally exposed to substances. So we will share that information with this committee and just wanted to provide that information on this funding source for the opioid settlement funds. And now I think we pass it over to Marla.
Good afternoon. For the record, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services. I just wanted to very quickly highlight, back on slide 6, so the Division of Child and Family Services, we provide children's mental health services related to community-based and residential child and adolescent mental health services in Washoe and Clark counties. We also have early childhood outpatient treatment, intensive care coordination, crisis support training, and we support victims of crime through financial assistance. In response to demands of the community and the courts, DCFS has expanded its services at Desert Willow Treatment Center, which is our children's psychiatric hospital, to ensure the provision of applied behavioral analysis services to youth who need that service as part of their treatment plan. And then when we go to slide 16, what I wanted to highlight, and what often comes before this committee, are the various policy committees or other committees that are out there that the division has some role with. And so what I wanted to highlight today is the Commission on Behavioral Health. So pursuant to NRS 433.314 and .316, the Commission has very broad powers over policies related to development and administration of services for persons with mental illness, persons with intellectual disabilities, developmental disabilities, substance use disorders, co-occurring disorders, and a role with services to prevent mental illness, intellectual disabilities, developmental disabilities, substance use disorders, and co-occurring disorders, and well as services provided without admission to a facility or institution. So under this broad oversight, the division is required to send our policies related to Desert Willow Treatment Center and our other inpatient facility, which is Psychiatric Residential Facility, PRTF, Residential Treatment Facility North in Reno. We are required to send our policies for approval to the Commission. The Commission, as it relates to specific authority for children, is guided by NRS 433.317. And you can see there that the Commission is required to appoint a subcommittee on the mental health of children to review the findings of each mental health consortium. So it's a very convoluted step-by-step system that gets to some high-level policy issues that affect operations in the division. Now, once that subcommittee is created, they are required to, again, if you look on the next slide, to consider the recommendations in the long-term strategic plan for provision of services to children with emotional disturbance that were developed by the various consortia. There are 3 consortia in the state of Nevada. That concludes my portion of the presentation, just to highlight that interaction that we have. Thank you.
Chair, committee member Stacy Weeks for the record. I'm going to go over our role at Medicaid and some of the work we're doing with our sister divisions on the Children's Behavioral Health Transformation Project, which is part of our Department of Justice settlement agreement that was recently signed by the state. Just real quick, when we look at the data of the kids that are covered in Medicaid, so like I mentioned earlier, nearly half are covered by Medicaid and CHIP in Nevada, and nearly half of kids are. About 1 in 6, we estimate, have a diagnosed behavioral health condition. Often there are non-diagnosed behavioral health conditions, but these are the numbers that we have before us. As you can see, that out of that bucket, about 6% do have also a co-occurring disorder, substance use disorder, or an intellectual developmental disability. This data also tells us the majority live in Clark County, like most of our recipients in Medicaid, so there's probably no surprise there. About 1 in 12 with serious emotional disorder in Medicaid are also in our state's foster care system. In general, it affects both girls and boys and children equally when we look at the data. I wanted to go over a little bit about PRTF placements. Administrator McDade Williams mentioned our psychiatric residential treatment facilities. These are facilities in our state that do house and treat children with serious behavioral health disorders. When we look at the rates of out-of-state stays, they have gone down a little bit over time since 2021, but the numbers are still, unacceptable. Of course, there's about 154 youth are placed in facilities, and these are facilities outside of Nevada. So when you look at sort of those out-of-state stays, there's still a lot of kiddos being sent out because we don't have adequate resources in this state. That leads us to what happened with the U.S. Department of Justice. They came in under the Americans with Disabilities Act and found Nevada out of compliance. When you provide a state-funded service or coverage like Medicaid, you have to ensure that that coverage allows individuals, adults and children with disabilities to live in their communities. So when you are only providing services that are state-funded or federally funded as well, that are only allowing kids and families or adults to have institutional settings for treatment, that actually violates the ADA. And so they found the state out of compliance. And so the last 2 years, we have been negotiating, the department has been negotiating with the U.S. Department of Justice on an agreement, which was signed, I think it was December, it feels, or maybe it was January. Thank you, January. It was a very long process, but we are excited about the work ahead. I think here is just a real snapshot. It's a 5-year agreement. There's a lot of work to be done. We can send the link around to members if you're interested in learning more about this. At this time, Medicaid is the leading agency for implementation because we have the funding as the payer to really develop the services in the program. But we're working closely with our sister divisions because, as you heard earlier, we all have a role to play in working on behavioral health challenges in our state. Let's skip over to this. So when you look at this slide here is just a real snapshot of what a system should look like. And those arrows, those green pieces, are kind of where in the agreement that was highlighted in the settlement agreement that we need to address in our state. So when you look at the care continuum, you really need to have each of these bubbles adequately addressed. So the first one here is early identification intervention. So right now we need to make sure kids are getting screened, they're getting assessed, they're getting treatment early. The earlier we get to find children in the system or in the school setting, the better. It's often if you go upstream, hopefully that avoids the longer term effects of serious emotional disorders. We also look at our state and we know that we lack outpatient community treatment, especially around children behavioral health. And so that is an area that the agreement does highlight a lot of new services for us to set up and to ensure that those benefits are available in our state-funded coverage program. The other piece here is crisis response and emergency. This is an area that DBPH is working hard on, is the mobile crisis, the statewide system. We're also looking at Medicaid, at new ways of funding these services to really boost that those services statewide. And last but not least is the one bubble that if we were going to do these in proportions to what we have in the state, this would be our largest bubble right now. This is where really kids are going. It's either inpatient treatment or residential. There's very little services in the home and community to help kids stay in with their families at home. This here is a real quick snapshot of those new services or some of the services that we will be improving. Wraparound services is a service that would be provided to the child and family if they're identified as having a behavioral health challenge. There would be almost like what you think of a caseworker that would work with the family and ensure that they're getting access to all the benefits and community services. That would be a new service. Family and youth peer support is also a new service we're bringing online. Individual and family therapy we currently cover, but our rates we looked at were pretty inadequate, so we did invest some funding into those rates that will be going into effect soon. Psychosocial rehab services right now are very limited to our foster care population primarily, so we're expanding that to any child that needs these services in the home. And planned and emergency respite. This is a new service, and it's typically not a Medicaid covered service, so we'd have to seek a federal waiver to waive rules to cover it. And so we're looking at doing that. On the side here are all the services, many of these we cover today, but we're looking at ways to improve them with rate increases, removing certain barriers like prior authorization on crisis response, which should never be there, right? So we remove that. Medication management, ensuring families know obviously how to get these services in their community, and that is the goal of this new effort. This is a quick timeline for our work. I will tell you it's very aggressive and ambitious, but we're up for the task, I think. We have the funding, which is very helpful in Nevada, thanks to the legislature and the governor and the hospital association, all the hospitals that were at the table in agreement that we could use 15% of the private hospital tax revenue to use to match with federal Medicaid dollars to support behavioral health needs and rates in Medicaid. And we are focusing on primarily those rates and reimbursement on children's behavioral health services. This here is just a high level of all the stakeholder and community engagement that we're doing. If you're interested and you want to know how to plug in, or you want people to be engaged that may not be, please let us know. It's a pretty big effort. And Jensen on my team, she's our innovation officer, is leading this. But every agency is involved in some way or some form or fashion. We're also working with our Office of Attorney General on ensuring compliance. Right now, this is sort of our high-level progress towards compliance. As you can see, right now we are pretty low on compliance under the agreement. We're just starting out. We are just starting the stakeholder work. We're working on dashboards to start monitoring and tracking children and where they're at in the system publicly, so you can see how we're doing as a state, as well as you can see over time as we develop benefits, get them online, really hopefully develop a provider system. That's always a challenge in our state, is getting the providers to do these services. So how do we design the rates to adequately do that is something we're working on. The goal is by 2029 to be full compliance by the end of that year. But if we don't, then we will have to extend the agreement. So that is what we're facing right now. Real quick, I mentioned the financing mechanism. None of this would be possible without this funding. So most states don't have this when they start these agreements. Most states have to go back to their legislature and ask for hundreds of millions of dollars, and we are lucky that we don't have to do that. So that is really, it's been a huge saving grace for all of us in working on this. I mentioned earlier we're looking at our PRTFs in the state. Obviously, you can't remove the need for some kids needing institutional treatment, so we are looking at ways to make these settings better in terms of safety and quality and ensuring that they're sustainable and that there's enough of them in state and not out of state. We're doing a new flat daily rate of $800. We're also doing a $150 add-on rate if they accept children with complex needs, especially our younger kiddos who are really hard to find placement. Also, we're doing a quality add-on of $50 when facilities are meeting certain quality metrics, including making sure kids aren't staying too long in the facility, but also when they're leaving that they're successful in transitioning. We don't want kids being kicked out without being successfully transitioned into their community. These are just some high-level things that we're looking at doing. Some of this is in the governor's budget. A lot of these I mentioned earlier. We are adding a couple new services or a couple different reimbursement methods to try to boost access to some of these services in our community. And I think that's it. So we're going to stand for questions. Thank you.
Thank you very much for the presentation. We appreciate the detail, and we will start with questions. Assemblymember Gray.
Good afternoon. Thank you, Ms. Weeks. Good seeing you again. A couple of quick questions that relate to each other. Where in your department do child abuse investigations fall?
For the record, Marla McDade Williams. Child protective services as well as child welfare services are managed through what we call a bifurcated system in the state of Nevada. So the Division of Child and Family Services manages rural child welfare in the 15 rural counties. Washoe County and Clark County manage child welfare investigations in their own counties.
Okay. Who has oversight of the investigators or whoever's looking at them to make sure that all cases are addressed?
Again, for the record, Marla McDade Williams. Each jurisdiction has their own child protective services system. There's a quality control, a quality assurance that goes into each case. So if a call comes in, the call is taken by the person who is assigned to take calls for that day. They discuss the case with a supervisor to determine whether or not an immediate investigation is required or not. And then that decision, I believe, is verified again by another level of supervision on how to classify it. Some cases we call information only. Some, are a higher priority. So depending on where it gets classified, we assign a resource out to do an investigation. There are situations where calls come in, for example, someone is homeless, and whether or not the issue itself of being homeless is a neglect issue, we look at whether or not that child is being cared for, whether they're homeless or not, and we make those decisions because homelessness in and itself is not defined as neglect. So there is oversight. If there is a situation where someone believes that we inaccurately assessed a case, it gets elevated up through our deputy administrator. We have a systems advocate that complaints can come through the systems advocate. And eventually, if they aren't resolved at that level, they come to my attention, and I can look into the case and determine whether or not we handled it appropriately.
So that review happens on every report that comes in?
There is a quality assurance review, I believe, on every report that comes in. Again, just a quick assessment of the facts that came forward. Not always an overturning of those decisions, if that's the question, because you're looking at the facts that are presented in front of you. Again, if there was more concern about it that got elevated, then there would be a different level of consideration of that report.
Okay, thank you very much, and I would really like to schedule a meeting with you sometime. Thank you.
Thank you. Next up is Assemblymember Nadeem.
Thank you, Madam Chair, and thank you so much for doing such a great work. It's a very much needed services that you're gonna provide. So my question is that all these services are mostly covered by the Medicaid. What about the other private services? Are they gonna follow it, or there's any negotiation going on with this? Because this is very, very important. These services they're amazing.
Chair, committee member, Stacy Weeks for the record. Typically when Medicaid covers something, there is a demand in the market, and sometimes health plans in the private market will follow. I think that is always the goal. The challenge with private insurance is that if you add a benefit or mandate something that's not currently covered under the Affordable Care Act, the state has to defray the cost. So if there is an intensive behavioral health service that's not covered today, and there are some in the private market, that would cost the state money to offset the premium costs to the consumers. So I think it's just going to, there is parity and all the other things that go along with the ACA to ensure behavioral health services are included, but some of those intensive services for children are not, and it just depends on the insurer. So it would require some kind of mandate, but again, that would be a state cost.
Okay, thank you.
Thank you. Assemblymember Jackson.
Thank you, Chair. I know you mentioned removing prior authorization for certain services. You mentioned removing prior authorization for crisis intervention services. I was under the assumption that this was already no prior authorization needed for crisis intervention. Is this more for like all HMOs? Because I know fee-for-service doesn't require a prior authorization.
Chair, committee members, yes, that is correct.
And then, say if I know there's legislation proposing homeless services, would that fall, if approved through legislation, would that fall under the behavioral health services?
Cody Finney for the record. Through the chair to Assemblymember Jackson, do I understand correctly that you're referencing the discussions of homeless services in Las Vegas? So, forgive me, please go ahead. So those services that would be provided, that are proposed to be provided there, would most of them, it is my understanding, would qualify to be covered by Medicaid, but they'd be provided by community providers. Am I answering your question?
Yes, thank you.
Thank you. Assemblymember Hibbets.
Thank you, Chair. Quick question on forensic mental health services. NRS 178.425 is the requirement to provide court-ordered services to restore individuals to competency. And according to that NRS, it says the judge, in part, the judge shall order the sheriff to convey the defendant forthwith together with a copy of the complaint. Forthwith has been determined by the courts to mean within 7 days. How far away are you from how far away from 7 days are you from getting people there, and what is the plan to correct that?
Thank you, Assemblymember Hibbets. Through the chair to you, the 7-day rule does come from some case law in other states, and in Nevada, that forthwith is all we have in statute. Currently, we are using a number of approaches to address the waiting time, the average time that it's taking from the time of an order to the time that we are able to admit those individuals has been about 70 days. My assessment of the situation is that 21 days would be very reasonable, and 7 days will be very difficult to meet. However, we do have a multi-pronged approach to getting those folks into the services that we have both north and south. We've also been having staff going into jails to see if we can have individuals diverted to other sorts of services if they don't, in fact, need to be admitted to those services. We've got jail-based services happening both at the detention center in Washoe County and Clark County to get folks started with some treatment before they're admitted to us. And the governor's budget did include the construction of a new facility in Las Vegas to really meet the demand that we have for this.
Vice Chair?
Thank you, Madam Chair. Just wanted to, again, really congratulate you all for doing such great work. And I know it's a lot, and you have a whole lot on your plate. In that same sentiment, I know that all the slides was very, very informational. But I'm actually looking for your stats on your recruitment strategies or staffing level. Are you, I know it's a tough question to ask these days on vacancies, but I just want to see if you're running with a full team, how many vacancies do you have, and then are there some recruitment things that we're doing to recruit more mental health professionals to stay and work in Nevada?
Thank you, Vice Chair. So I'll start. We have a little bit of a competition going between the administrators. So I'm going to start. And overall, for my division, we've got about 1,822 positions total. 1,500 and some are full. So we got about a 15% vacancy rate overall. That's across public health and behavioral health. So I am not winning.
Chair, committee member Stacy Weeks for the record. We currently have an 8.5% vacancy rate, which is exciting, but we only have 300 staff, to be fair. But to your point about mental health professionals, I think there's a lot of efforts at the university level, too, that we're trying to work with them on finding ways to get more candidates in the state. I don't know, Administrator McWade, or Williams, if you want to go.
Thank you. For the record, Marla McDade Williams. So I have the unfortunate position of having the highest vacancy rate throughout the department. We do have, through Desert Willow and all of our other clinical services, significant vacancies. Overall in the division, I have a 24% vacancy rate, but that also includes our juvenile justice facilities, which again are very hard for us to maintain staff in. Deputy Director Litz just handed me this information. Our vacancy rate by occupational group, medical health and related services, is 36%, and that includes psychiatric nurses, mental health technicians, and mental health counselors. Social services and rehabilitation is 29.93%, and that includes social workers, family services specialists, and group supervisors. So social workers and the family services specialists, and the group supervisors, those are all positions in my division that we struggle with maintaining. In our clerical, it's 13.9%, fiscal and management 11%, and all other departmental, it's 8.13%. The division did, through some American Rescue Act dollars, put forward funding for nurse apprentices. So, that has been very successful at UNR and UNLV. I know we continue through the department to have a partnership with the Nevada Public Health Foundation to offer scholarships for social workers. So, there are some efforts. The Governor Lombardo has done hiring events that have been significant and in helping us, my division particularly, in filling some positions because we can look at applications on site, hire employees on site. One of the big challenges for us is criminal background checks and just the time it takes, the length of time it takes to get those done. But there are efforts, and we have made progress. I'm happy about the progress we have made in some of our areas. It's gone down significantly. When I started, I think we were almost at 40% in our IT vacancies, and now it's down to like 11 or 12%. So there's progress. Just lots more needs to be made.
Wow, those are amazing. I mean, I've been to many presentations, but they have everything at top of their head. So I congratulate you all for knowing all your numbers, just the back of your head. So thank you for all the hard work, and we're gonna collaborate as much as we can to help some of these gaps. Thank you, Chair.
Thank you, Vice Chair. Members, any other questions? I do have a couple, if you will indulge. I'd like to go back for a quick review of the crisis response services. I'm curious to know, we're offering 24/7 access to trained counselors through that 988lifeline.org, right? But can you talk a little bit about how are we doing, what's the efficacy? Do we have 24-hour counselors that are available throughout the state? Are the rurals experiencing, less providers and an inability to respond versus Clark County or Washoe County? And are we able to meet the needs of our youth crisis response?
Cody Finney for the record. Thank you, Chair. So currently, when you call 988, that answer center is in Reno. We have a contract that was recently approved and executed that will allow us to set up an additional call center and dispatch hub that will be in Las Vegas. And they've recently started using geolocating, is my understanding, with most of the telephone providers, which does not allow us to know, or us, the 988 response, to know exactly where someone is, but it does allow the call to be routed to the nearest call center. In the past, it had been done by area code. And as many of us know, the area code doesn't mean the area anymore because we're all carrying them everywhere. So lots of development in this area. I am certainly not the technical expert. We could get you detailed information from the Bureau of Behavioral Health, Wellness, and Prevention. But what I can tell you is that today, if someone reaches out to 988, they do get an answer. We're not having as many of those calls answered in state as we would like. It's about 70%. The rest of those calls then roll over to backup agencies in other parts of the country. So not everybody is getting a local response at this moment, but the metrics that we're using as we move through the development of this system are designed to improve those pieces. The second part, after the call center, the second part is the mobile crisis response. We've got a number of models of mobile crisis response that are currently happening in Nevada. We don't have complete coverage of the state. So part of our mission in the next, in the implementation of this contract, is to identify how we address that and how we maximize technology in order to make sure people who are physically remote can still get services and talk to someone when they need to. The third part of that system is the crisis stabilization centers. And we've got 2 of those opening in the near future, one in the north and one in the south. We're very hopeful that this will really break the barrier of having those open, because we know in the south we need more than one. And we continue to talk with provider partners that may be interested in providing those services, and working with our partners at Medicaid to make sure that those are adequately reimbursed so that those business models can work.
Thank you for that explanation. I appreciate knowing that, and then would further follow up as we progress throughout this legislative session. How can we be helpful to provide some of those solutions or ideas maybe to support your efforts? I would like to also congratulate you on your care of Nevadans that need assistance. For me, I think that's the most important part, which you all know. I'd like to follow up. I have another question. There are 154 youth placed in facilities outside of Nevada. It's on slide 23. And I just have an overarching question. What does it take? What is it going to take to get them placed here closer to their families?
Chair, committee members, Stacy Weeks for the record. So under the DOJ agreement, there are two paths, right? You could build more PRTFs, or we can create home and community-based services to hopefully avoid a lot of these kiddos needing those services. The DOJ agreement is really pushing us to the latter here, which is home and community-based services. One of the things that we're hoping, though, is that with the rate increases, we will see a couple more of these facilities come online in the state, or at least expand their footprint. But what we don't want to see is just a bunch of PRTFs that would actually violate the agreement. So it's a balance in meeting those needs.
Thank you. Administrator Weeks, would you explain to the committee again what is a PRTF?
Chair, committee member, Stacy Weeks for the record, my apologies. It's a psychiatric residential treatment facility. We used to call them residential treatment centers in Nevada, but under federal law, they have to be licensed by Administrator Cody Finney's shop, ACQC, as a PRTF now, which has more stringent requirements. And I think Administrator McWade Williams, do you have something you want to add to this?
Thank you. For the record, Marla McDade Williams. I think one of the other considerations is, although we could bring children back into state, some of these kids are in placements that they're in because they have either extensive behavioral health needs, dual diagnoses, or they're there for some type of a specialty care that we would also need to build in the state of Nevada. For example, juvenile sex offenders, right? There's right now no plan that I'm talking to anybody who is stepping up to provide a facility for juvenile sex offenders. Youth with eating disorders, right now, not really somebody stepping up to provide that service. In Desert Willow Treatment Center, as I noted earlier, we have worked with the Division of Healthcare Financing and Policy over last year to allow us to bill for applied behavioral analysis inside the facility on top of the rate that we're getting. But there's just so much more need. So, people who are, especially for applied behavioral analysis services throughout the state, that really looking at that need and figuring out, with all of the training that we are doing for behavioral health providers, whether or not they're going to be able to treat kids across the board or specializing in one. And then, we are trying to, we have a contract, again, working with the Division of Healthcare Financing Policy for care management, but wraparound services, and trying to build that capacity in the state. And it's very difficult. And so we are really trying to focus on getting that stood up, because Medicaid will struggle if we aren't able to stand up those types of services with the providers that we do have in this state.
Thank you. Thank you for that. And so that leads to my last question, is the providers, the home and community-based services waivers, right? So if that's how we can grow services, home and community-based services, the first part of my question is, do you then, as the administrator in the division, do you have the ability to just create a waiver application to federal Medicaid, or is there another mechanism that the legislature has to do, or the executive branch, in order to get us to grow home and community-based services?
Chair, committee member, Stacy Weeks for the record. To be honest with you, I don't want a waiver. The waivers are very complicated, and they limit our ability to be flexible and integrated. We're actually looking at a state plan amendment. It's called 1915I. We believe we have full authority to move forward under the DOJ agreement and directive to seek that authority to implement a home and community-based coverage for these kids, and also ensure that benefits integrate in their medical benefit. What we don't want to see is that there's these siloed systems, like here's your waiver services over here, and here's your medical coverage over here. It should be one child, one benefit. So that's what we're trying to do with CMS. It's not going to be easy. We're one of the few states trying to do this, but I think that's the approach that we're trying to take. So thank you for the question.
Thank you, Administrator Weeks. And so then my follow-up would be, if we are able to do, it takes a while to complete an application. How long until you feel like we would be able to pivot services under this new 1915I? And then how do we grow the provider network? Or are there adequate providers across the country that we can just tap into?
Chair, committee member Stacey Weeks, for the record, that is a challenging question to answer. I will just say that a lot of these services don't even require a special authority. I think the big one is respite care. That's going to require a 1915I or a waiver. But we're looking at our 1115 waiver, try not to get too technical here with you guys, but my point is, we're going to try our best to get wraparound up as quickly as possible. Family peer supports we should have up by, if not, depending on CMS right now, we could get started by April right now with our system to start billing, and if people can get enrolled, the whole bit. So individual and family therapy, psychosocial rehab services, some of those are tied to our 1915I, but those usually don't take as long as our C waivers that you're probably more familiar with our other home and community-based services. That's why we're trying to go this other route, so it'll be shorter. But to your question about what do we do to get providers online, I don't think we have enough providers. Even those folks that work to train, even peer supports, there aren't very many. If we were to start enrolling today, we don't have really very many to enroll, even though they've done a lot of work in this space. So we're going to have to think about what incentives do we provide, what are those rates. So we are looking at that. We do, through with DCFS, we're working on a care management entity pilot through ARPA funds with Magellan, which is trying to stand up some of these services, start funding them. I think the challenge has been, like Administrator McDade Williams said, we cannot find the providers. So what we're looking at is actually having that entity start providing infrastructure funding to providers that want to stand up these services. Louisiana took a similar approach. They provided infrastructure grants to entities that wanted to stand up these community agencies that would provide wraparound family peer supports and do some of that care coordination really in the community for families. We're hoping maybe we could do a similar model with some of that ARPA funding. So that's what we're looking at next. But it is a challenge.
Thank you for that.
Madam Chair?
Yes,
if
go
I
right
could
ahead.
just, Marla McDade Williams, I just did want to highlight our system of care grants. We have a 5-year system of care grant that we are targeted towards also doing provider training. And so we are currently in the process of standing that grant up, and there will be real training opportunities for professionals throughout Nevada. Those that want to move forward and strengthen their skill set in certain areas, we are making that available through that grant. I'm very hopeful. I have high hopes for it to make a dent in some of our needs.
Thank you for that. Thanks for the presentation and the answers to those questions. Members, any other questions? Seeing none, I will give you an opportunity if you'd like to make a closing comment. It's completely up to you.
Chair, committee member Stacey Weeks, for the record, thank you for having us. We're looking forward to working with you this session. So have a great weekend. Thank you. Mm-hmm.
Assembly Member Gray.
Thank you. I meant to open my last comment with, I just really wanted to tell Ms. Weeks thank you. I was having an issue with a constituent and with a bill that had been passed, and she went above and beyond, and her staff went above and beyond to make sure the situation got rectified, and it was really good. So thank you so much.
Thank you. I hope that you can hear that echo from many of the members on this committee, and we very much appreciate your hard work on behalf of all of our citizens. So thank you for that. Okay, we will close that presentation and move on to our next order of business, which is public comment. So we ask that a public comment be kept to 2 minutes. Staff will be timing each speaker during public comment to ensure that everyone is given a fair opportunity to speak. We ask that you clearly state and spell your name for the record, and then we'll start your time. If there's anyone interested in offering public comment here in Carson City, please come forward. Also in Las Vegas or on the telephone lines. If you want to reach us.
Chair, the line is open and working,
Thank
but there
you.
are no callers at this time.
Okay, thank you. Okay, seeing no one interested in public comment, we will conclude our meeting today. Members, are there any comments before we adjourn? Thank you. This meeting is adjourned. Happy Friday.